Should we get started? All right, good afternoon, everybody. We're going to get started with our EPI seminar for today. So I am so excited to introduce Dr. Christina Schumacher, who's an epidemiologist and assistant professor at the Center for Child and Community Health Research in the Department of Pediatrics at the Johns Hopkins School of Medicine. She focuses primarily on the translation of evidence to public health practice for the prevention of sexually transmitted infections and HIV. She has expertise in the application of epidemiologic principles and methods to public health surveillance data, programmatic data, and electronic health record data to inform the development, implementation, and evaluation of public health in clinical practice. And she collaborates closely with multiple public health agencies in the US, including the CDC. And she has experience in sexual network studies and mathematical modeling, leveraging public health surveillance, clinical research, cohort data to improve understanding of sexually transmitted infection and HIV transmission dynamics. And on a personal note, we entered the EPI program together at the Johns Hopkins School of Public Health. So I've known Christina, we have been friends for more time than she wants me to admit on this public record. But I just want to say that I'm just delighted to have her here for seminar. So take it away. Thank you so much, Christina.
Good afternoon, and thank you for having me come speak with you today. My goal this afternoon is to demonstrate how we leverage some existing clinical surveillance and research data to gain some deeper insights into how reduced clinical capacity during the COVID-19 pandemic may have impacted STI transmission, and specifically gonorrhea transmission in Baltimore City, Maryland. So first, just to give you a backdrop of what was happening before COVID hit. Bacterial sexually transmitted infections such as chlamydia, gonorrhea, and syphilis are longstanding public health problems. Diagnosis rates have been increasing for quite some time. In 2019, reported annual diagnoses of all three infections reached a historic high in the United States for the 6th consecutive year. Increases in reported diagnoses had been observed among both men and women across all age groups and across multiple geographic regions throughout the United States. And racial and sexual minorities, such as men who have sex with men, bear disproportionate burdens of STIs and HIV. For example, in 2019, 31% of all reported chlamydia, gonorrhea, and syphilis diagnoses were among Blacks in the United States, who comprise only 13% of the total population. Additionally, previous work has shown that syphilis and HIV risk and lifetime risk of acquiring HIV among Black compared to white, gay, bisexual, and other men who have sex with men are 3.5 and 5.5-fold higher, respectively. And so this was the backdrop of multi-year increases in STI incidents that when COVID-19 emerged. And since the declaration of the COVID-19 national emergency in March of 2020, there were severe disruptions to the delivery of sexual health services, and specifically STI, HIV clinical, laboratory, and prevention services. This resulted in substantial declines in observed laboratory testing, and one study by Casey Pinto and colleagues out of Pennsylvania used national data from the Quest laboratory and showed that chlamydia and gonorrhea testing volumes decreased by 60% in April 2020, and by June of 2020 were still suppressed by about 15% compared to pre-pandemic testing volumes. We also saw large, and by large I mean 50% or larger, declines in public health managed sexual health clinic patient volumes across multiple jurisdictions in the United States, and several studies reported decreased access to HIV and HIV pre-exposure prophylaxis care among gay, bisexual, and other men who have sex with men. We also saw reduced capacity to conduct routine public health, STI, and HIV services. So we saw redirection of prevention program staff to the COVID-19 response. And this decreased the capacity of a public health department to conduct follow-up and contact tracing for STIs and HIV to ensure that infected individuals were treated, and also reduce capacity to notify persons of their potential exposure and encourage them to be tested and treated. In California, for example, 40% of their local health departments reported 75% or more of their prevention program staff had been redirected to the COVID-19 response. And this redirection had lasted for quite some time. And another study showed that among 65 public health department prevention programs throughout the United States, that 87% of these public health departments reported that their staff were leading, staffing, assisting, or otherwise supporting COVID-19 contact tracing efforts, and that their provision of STI services declined by at least 20 to 30% during this time. So before we talk about what this means for STI transmission, I want to take a quick diversion into infectious disease theory and the reproductive rate equation, which provides a framework from which to understand how these mitigation measures might be impacting the transmission dynamics of STIs. So if you recall, the reproductive rate describes the average number of new infections that arise from one infected person in a population at a specific moment in time. The reproductive rate can be described mathematically as the product of three factors. Beta, the probability that an infection is transmitted given contact between susceptible and infectious individuals. C, the average rate of contact, and in this case, sexual contacts or sex partnerships between susceptible and infectious individuals. And D, the average duration of infectiousness. When the reproductive rate is greater than 1, incidence will increase. A reproductive rate of 1 is steady state or endemic incidence. And conversely, when the reproductive rate is less than 1, incidence will decrease. Interventions that decrease any one or combination of these three factors would lead to a decrease in the reproductive rate. However, in order for incidence to decrease, the decline in any one or combination of these factors needs to be large enough such that the reproductive rate falls below 1. So for example, if an intervention reduces the overall reproductive rate from 2 to 1.5, you would still have increased incidence, but that spread would occur more slowly. So with this framework in mind, let's talk about how mitigation measures could have impacted STI transmission. So how might reduced capacity for clinical laboratory and prevention services be impacting STI transmission dynamics? Well, reduced delivery of sexual health services may lead to a decline in diagnoses and then subsequent treatment. This then would increase the average duration of infectiousness, which then increases the prevalence of infectious individuals in the population. All else remaining constant, the increased prevalence of infectiousness may increase the probability of contact between an infectious and susceptible individual, thus putting an upward force on the reproductive rate, leading to opportunities for increased incidence. But we also know, because we all lived through COVID, there were also mitigation measures such as social distancing. And this may have impacted behaviors that have previously been associated with STI acquisition. So for example, the emergency orders that closed or restricted attendance in public spaces, such as bars and clubs, may have decreased attendance and therefore opportunities for important subgroups, including sexual minorities, to meet new and casual sex partners, thus limiting sexual contact between infected and susceptible individuals. Several studies reported on sexual behaviors during the early months of the pandemic, and the results of these studies were mixed. Some reported substantial declines in reported number of sex partners during the pandemic, while others reported increased or no change in the number of sex partners, and others reported some variability over the pandemic time period. So again, returning to our framework, if social distancing led to decreased STI and HIV risk behaviors, we may see population-level declines in the number and type of sex partners. This then would decrease the average rate at which sexual contact between infectious and susceptible individuals was occurring, which would then decrease the reproductive rate. So in summary, we know that various mitigation measures for COVID-19 may have led to substantial declines in the capacity to deliver clinical services, which would lead to the upward pressure on the reproductive rate. And at the same time, we may have had population-level changes that would put a downward pressure on the reproductive rate. And so we're left with, we don't know what's going on with incidence. So, but early on, a bunch of people were very concerned about this issue. And there was an early modeling study by Sam Jennis and his colleagues out at Emory that explored what could happen to HIV, shown in the left panel, and STIs on the right panel, and showed what would happen with incidence in these two conditions among gay, bisexual, and other men who have sex with men under various scenarios of sexual health service disruption and social or sexual distancing. The black lines in these charts which are labeled baseline, represents incidents without any service disruption or social distancing, or in other words, a projection of what would have happened had the pandemic not occurred. The green line shows a projection of 3 months of social distancing, but no changes or disruptions to service delivery. And you can see it mirrors the baseline quite closely. And in some cases, for STIs, it shows overall decreased incidence. But the red and the blue lines up top, where you see an epidemic peak that comes down but doesn't quite come back down to baseline, represents projected incidence trends for 18 months of service disruption with, which is the blue line, and without, which is the red line, any social distancing. And the message here is that prolonged service disruptions could have drastic consequences for both STI and HIV transmission. Now, this paper was published in a preprint on medRx in 2020. And as we're still in the midst of intense redirection of services and not really quite understanding what was going on with STI and HIV transmission, my colleagues at the health department and health departments all over the country were kind of what is going to happen. And we're very concerned about what the future would bring. So then we need to look at, surveillance data can kind of tell us, well, what really happened? And this chart shows data from the CDC on weekly reported diagnoses of chlamydia in blue, gonorrhea in orange, and syphilis in purple. And this represents reported diagnoses in 2020 relative to the reported diagnoses in 2019. So time is shown in weeks, and that's displayed on the x-axis, and the y-axis shows the relative proportion. So the dash horizontal line represents 100%. So for weeks where the trend line is above that dashed line, there were more reported cases in 2020 than there were in 2019. So if you look, over time, in early 2020, there were relatively more diagnoses of all three conditions in 2020 compared to 2019. And then reported diagnoses plummeted immediately following the declaration of the national COVID-19 emergency in mid-March. And then reported diagnoses gradually returned to 2019 levels by summer and took off around the time that many states were lifting their strictest emergency stay-at-home orders. By the end of 2020, diagnoses of syphilis and gonorrhea were substantially higher than the reported diagnoses in 2019, but the number of chlamydia diagnoses remains similar. And we saw similar patterns to this reported throughout Europe and in multiple state and local jurisdictions throughout the United States. What is important to note here is that gonorrhea and chlamydia testing are performed on the same specimens. However, compared to gonorrhea, chlamydia is much more likely to be asymptomatic, and a majority of chlamydia diagnoses occur through routine annual screenings of sexually active young women. And thus, trends in reported gonorrhea diagnoses are much more sensitive to changes in screening practice than gonorrhea. In addition, gonorrhea is much more likely to be symptomatic in men with urethral infection, which I understand is quite uncomfortable, and they will seek care for that condition. So what the blue line for chlamydia diagnoses suggests is that screening practices may have remained suppressed throughout 2020. And the fear was that there were increasing trends for gonorrhea and syphilis, and that these were underestimates of the true underlying incidence. And so what we sought to explain was the impact of the pandemic era disruptions to sexual health services on STI transmission, specifically in Baltimore City. And I'm going to use gonorrhea as an example throughout the rest of this talk. So first, some background context about gonorrhea in Baltimore. Baltimore is home to one of the worst gonorrhea epidemics in the US. We've been winning at that for quite some time, decades, I think. There are about 4,000 gonorrhea diagnoses reported to the Baltimore City Health Department annually. And in 2019, our gonorrhea diagnosis rate was 3.5-fold higher than the US national diagnosis rate. And that same year, our gonorrhea rate ranked third among US counties and independent cities, and we persistently rank among the top 10. And in Baltimore specifically, we were concerned about the increase of decreased capacity at city health department sexual health clinics. We have 2 public health managed sexual health clinics. In pre-pandemic, they reported about 13,000 clinic visits annually, and overall report about 1/4 of all gonorrhea diagnoses in the entire city. And through March 2020 to February 2021, 1 clinic location closed entirely, and there were limited hours at the second clinic throughout 2021. for about an 18-month period, the BCHD Public Health Laboratory, which was co-located at one of the clinics, was closed, and then we had to send out laboratory tests to a private commercial lab. And in March 2020, the remaining clinic also pivoted from walk-in appointments to an appointment-based visit and implemented procedures to triage patient to in-person versus remote care. And while the capacity for in-person evaluations gradually increased starting in November 20, we still have not seen a return to the same clinic volumes. And so first, to look at how clinical services were impacted, we used electronic health record information during COVID-19 and a similar 18-month period pre-COVID-19. And we grouped visits of clinic visits into care episodes, and these were visits that occurred at least 14 days apart or less. And we looked at outcomes of testing or treatment for gonorrhea and examined these overall and among those reporting symptoms or potential exposure, although I'm just going to show the overall for simplicity today. So here is just a chart showing the overall number of patient visits to our clinical sites pre and post pandemic. And the important take home is just a visual. The black line is the overall number of clinic visits, and you can see the huge plummet in volumes and how we haven't quite returned back to that level. The bright green line is the telemedicine visits that we were able to implement that mitigated some of the issues with our ability to do in-person clinical visits, but didn't quite get us back up to the same level. And so when we look at what the overall changes were, even though we initiated via telemedicine and during the pandemic, these were about 72% of our overall clinic visits, at least were initiated as a telemedicine visit, and then some perhaps turned into an in-person visit based on what the patient stated to the provider. But we see, first and foremost, a 61% decline in clinical episodes. We also see an increasing number of visits per episode. So if you think about duration of infectivity and time to treatment, this would increase the time that someone would be from infection to treatment, and so could contribute to ongoing transmission. We also saw an increase in the proportion of patients that were symptomatic male patients, and therefore kind of sort of a decline in the asymptomatic screening patients that we were seeing prior to the pandemic. In terms of gonorrhea testing and treatment outcomes, first, if we look at just the overall who was tested in the proportion, we see an absolute decline ranging from 65% to 82%, depending on the anatomic site in overall testing volumes. And these decreased testing volumes can be partially attributed to declines in patient volumes, notable for urogenital testing and oropharyngeal testing. But if you look at the percentages of patients who were tested rectally, they were about the same. So largely, this is just a function of the decrease in patient volumes, but not entirely. As you can see, 42% of patient episodes seen during the pandemic were tested urogenitally compared to 78% pre-pandemic. And that was also a function of telemedicine and having to refer to another place for testing. Similarly, among those tested, positivity was similar compared to pre-pandemic. So among those who were tested, about the same proportion who are positive, but we see an absolute decline in the number of diagnoses at this clinic. And that again ranges from about 70% at the rectal site to 81% at pharyngeal site. However, the good news is, compared to pre-pandemic, patients testing positive for gonorrhea were more likely to be prescribed treatment. We also looked at presumptive gonorrhea treatment because at the time, particularly with telemedicine protocols, a lot of places, including Baltimore City, enacted syndromic management, which means talking about the symptoms, managing based on an inclination from the symptoms that the patient is describing, and not waiting around for a test, and in some cases, not even testing. And we see a 173% increase in the percentage of patients who were treated without a positive test. So again, some of these patients had they been able to come to the clinic and get tested, likely would have been positive. So this was a strategy that perhaps could have mitigated ongoing transmission. So the overall impact during the first 18 months of the pandemic, large decreases in patient volumes, large decreases in testing volumes, huge decrease in the overall number of gonorrhea diagnoses, and an increase in presumptive gonorrhea treatment. Now, recall I said that the Baltimore City sexual health clinics diagnosed about 1/4 of all reported gonorrhea diagnoses. So this could have a substantial impact on transmission in the city. So we knew that anecdotally that services were disrupted throughout the city, but we couldn't quantify those disruptions with this particular data set. So then we went to look at our surveillance data to see what happened. So the first thing we did was to look at reported gonorrhea diagnoses throughout all the city. This is based on routine surveillance data. And in order to be reported in the state of Maryland and indeed states across the country, you need a laboratory confirmation for it to be considered a gonorrhea case. And generally speaking, we look at this as a proxy for gonorrhea incidence. And this chart here just shows the reports of those laboratory confirmed gonorrhea diagnoses by month for 2019 and 2020. And what we see is starting in between February and April of 2020, during these strictest stay-at-home orders, we see a 34% in the number of reports of gonorrhea diagnoses, followed by an 80% increase from that nadir in April 2020 to October of 2020. And this mimics what I showed you earlier in the CDC data. And so the question is, what is happening? Is this increased transmission? Is this the delay in finding new cases? But all we have here are reported laboratory diagnoses. And in the context of suppressed testing, it's very difficult to interpret. So first, we wanted to see how routinely collected public health surveillance was impacted by changes to delivery of clinical care. And our hypothesis was that symptomatic cases may have been overrepresented in our surveillance data compared to pre-pandemic. Specifically, if this were true, individuals diagnosed during compared to pre-pandemic would more frequently report symptoms, be males with urethral infections, and/or a higher proportion would have received same-day treatment. So to explore this question, we use data from the STD Surveillance Network, or SUN surveys. SUN is jointly managed by investigators at Hopkins, me, in collaboration with the Baltimore City Health Department, and Baltimore has been a SUN site since 2008. And as part of SUN, we conduct enhanced surveillance activities among a random sample of all reported gonorrhea diagnoses. And this includes administering surveys to both the diagnosing providers and individuals who are diagnosed with gonorrhea themselves. And because these surveys are conducted among a random sample, the SUN data allows us to draw inferences about the universe of people with diagnosed gonorrhea as a whole. So what I'm going to show you is some information about changes in characteristics of persons diagnosed with gonorrhea during compared to pre-pandemic. And so this analysis included information from just over 1,000 during pandemic cases and 1,600 pre-pandemic cases who completed SUN interviews. And this represented approximately 6,000 diagnoses from each period. So first, we looked at a monthly time series for the proportion of cases that were symptomatic at the top in purple, that were males with urethral infections, blue in the middle, and those who received same-day or empiric treatment in the bottom in green. The dashed vertical line in these charts represent March 2020 when the national emergency was declared. So if we focus first on the symptomatic gonorrhea cases, they appear to fluctuate throughout the whole period and even during the pre-pandemic and during pandemic observation period. But the lowest proportion of symptomatic infections occurred during the pandemic in June 2020. But overall, this chart doesn't really show much difference in the proportion of cases reporting symptoms. The middle pattern shows a similar or slightly different trend, and in contrast to what we hypothesized, it actually shows a slight decrease in the proportion of cases that were males with urethral infections. And similarly, we also don't see any clear trend in empiric treatment as well. And then if we look at the actual proportions, and here we looked at the proportions and did some regression modeling to show the odds of being diagnosed with a particular characteristic during compared to pre-pandemic. And what we see here is, first, we also see reflected in the data the impact of the decline in services at our public health sexual health public health managed sexual health clinics, which went from about 23% of reporting 23% of diagnoses during pre-pandemic to 9% during the pandemic. But we also see a large increase in those reported by emergency department and urgent care centers. And then when we look at our indicators of symptomatic infection, we see no difference in symptomatic infection compared to pre, no difference in same different empiric treatment, and a statistically significant lower odds of male urethral infections during the pandemic compared to pre-pandemic. We also looked at some demographic characteristics, and here we see some differences. So compared to those diagnosed pre-pandemic, we see a decreased odds of diagnoses reported among minors, so those who are less than 18 years of age. We see an increased odds of diagnoses reported among those living with HIV, those who had a recent gonorrhea diagnosis, with recent being defined as within the past 12 months, and those who reported having insurance. There are some limitations to this analysis. It was performed on a random sample, and selection bias was likely minimal, although there may be some introduced by who agrees to answer the survey or the providers that were able to complete the forms we sent to them. The questions were, a lot of the questions are based on self-report, so there may be subject to recall bias. There was some misclassification of anatomic site of infection, although we did look at that and we didn't see any difference in the trends and inferences that we would draw. And generalizability may be limited to Baltimore City. The public health implications of this analysis, we saw that large decrease in the proportion of cases reported by our sexual health clinics, but we also saw a large increase in the proportion of cases reported by emergency departments and urgent care centers. And the no observed increases in the proportion of cases who reported symptoms or secondary indicators of symptomatic infection. This may suggest that patients who, pre-pandemic, may have sought care from BCHD clinics, sought care instead at emergency departments or urgent care centers, which would perform the same functions, same day, and care right away. However, this may have implications for the receipt of other prevention services, such as HIV testing or HIV pre-exposure prophylaxis referrals. And our prior work in Baltimore has shown that emergency departments and urgent care less frequently offer HIV testing to those diagnosed with gonorrhea, despite CDC recommendations that all persons receiving treatment or diagnosed with an STI also be tested for HIV. We also saw some significant changes in other characteristics that could either indicate a change in which populations had access to sexual health services during the pandemic, or it could also be a shift in groups that are important to gonorrhea transmission, and we can't draw a conclusion definitively from these data. So we still don't know exactly what the impact of service disruption on transmission was, nor have I addressed yet how social distancing may have impacted transmission. So for that, we turned to a research study that happened to be ongoing while the pandemic hit. And this is called the Understanding Sexual Health and Network Study, or USHINE, which was a prospective cohort study to improve understanding of network epidemiology of syphilis among gay, bisexual, and other men who have sex with men. We recruited from a variety of sites throughout the city. The inclusion criteria was cisgender men aged 18 to 45 who lived in a Baltimore City zip code and reported sex with a man in the past six months. And we enrolled participants between July of 2018 and ended enrollment right before the pandemic hit. And these men were followed every 3 months for up to 2 years. So the objectives of the analysis we were able to do with these data, we wanted to provide some insight into changes in STI transmission dynamics among MSM, and we specifically looked at differences among Black MSM to ensure that there was appropriate intervention. And we looked at trends in STI risk behaviors, access to sexual health services, and both chlamydia and gonorrhea overall and by race before and during the COVID-19 pandemic. The study population for this analysis included participants who attended any study visit occurring after March 13th, 2020, and who attended at least one study visit prior to March 13th. That was no more than 6 months between their first pandemic visit and their previous pre-pandemic visit. And we included up to 3 during pandemic visits through December 31st. So some participants contributed 4 visits total. Data collection included a CASI behavioral surveys, a face-to-face sexual network interview, and biologic testing for syphilis and triple site chlamydia and gonorrhea testing and HIV testing. During the pandemic, we were able to pivot to an interviewer administered behavioral survey via telephone or virtual platform like Zoom. And we were able to administer biologic testing for the triple site chlamydia and gonorrhea through an at-home self-testing kit. And that was launched starting June 23rd of 2020. So here's a schematic to demonstrate how we classified our study visits into pre and during pandemic visits. So I previously noted that study visits were classified using March 13th, 2020 as the demarcation for pandemic and pre-pandemic. And the pre-pandemic visit was whatever the most recent visit occurring prior to March 13th and no more than 6 months prior to their first during pandemic visit. And then in order to examine changes over time and in alignment with our timing of our 3-month follow-up visits, we categorized our pandemic visits into 3-month follow-up visit periods shown here. So pandemic 1 visits were those that occurred between April and June of 2020, pandemic 2 between July and September, and pandemic 3 between October and December of 2020. All measures were assessed using a 3-month recall period. We looked at a variety of outcomes. Sex behaviors, we looked at the reported number of total, new, and casual sex partners, and these were all dichotomized using their median pre-pandemic value. So for total partners, it was 3 or more partners, and new and casual were both defined using demarcation value of 2 or more. We looked at 2 indicators of access to sexual health care, whether or not the participant reported attending an HIV or HIV PrEP care visit in the past 3 months or they were currently taking antiretroviral therapy or HIV PrEP. And we looked at whether or not they reported a non-study STI visit or STI test. And we looked at chlamydia and gonorrhea positivity for those visits for which we had that data. Other factors with demographics and HIV status. So we examined these changes in each outcome over time and by race using some descriptive statistics and generalized estimating equations with modified Poisson regression, and we adjusted for the reported value of whatever this outcome of interest was at that pre-pandemic visit. So the results. We had among 417 enrolled participants, we included just over half, 231 in this analysis. And our baseline characteristics of those who were included versus excluded were similar by race, age, HIV status, syphilis history, reported number of sex partners, substance use, but they were significantly more likely to report access to sexual health care and STI testing. And among those included in the analytic cohort, 96% had a visit between April and June, 84% between July and September, and 62% had a visit between September and December. So we had pretty good retention. Most of those who did not complete the pandemic 3 visit were lost to follow-up, and those retained throughout the full pandemic 3 visit were similar to those who were not. Most of our participants were Black or African American, had completed high school. Only 6% reported they were not currently employed. The median age was 31 years. Almost 40% were living with HIV, and just over 40% had a history of syphilis infection. So this is a fairly high-risk population. So the first thing we looked at was a reported number of total sex partners in the past 3 months overall and by race before and during the COVID-19 pandemic. And this is a little bit of a busy slide. So here I just want to point out that overall, among all participants, all 3 of our sex partner indicators, the sexual risk indicators, declined throughout all 3 pandemic visits. And while not all of them were statistically significant, we see the same trend. For total number of sex partners and new sex partners, when we look at results stratified by race, we also see similar trends of declining reports of sexual partnerships compared to pre-pandemic. But we do see a slight difference in reporting of casual sex partners by race, where we see a trend of decreased multiple casual partners among non-Black MSM over time, but we see no change in this indicator among Black MSM. if we look at reported access to sexual health services, we see an increase overall in a Black MSM among those who report being engaged in HIV care or PrEP care, which, to be honest, was a bit of a surprise. We hypothesized that we would see the opposite, so this was encouraging. And we didn't see a change in engagement in HIV or PrEP care among non-Black MSM. We also see for the first two pandemic periods, decrease in the proportion who reported receiving non-study related STI tests in the past 3 months. And this was consistent by race. But then we saw no change in pandemic 3 compared to pre-pandemic in receipt of a non-study related STI test. So we're starting to see a little bit of a rebound in access to sexual health services towards the end of 2020. And now we look at gonorrhea positivity overall and by race. What do we see? Well, we see that gonorrhea positivity between the pre-pandemic and the pandemic 2 period, so that's July through September, and pandemic 3, which is September through December of 2020. So first we see a slight increase, and then we see a decline. And this trend is consistent overall among overall participants and by race, that we see the slight increase and then decline. But we also see, I also want to note how much higher prevalence is among Black MSM than it is among non-Black MSM. And none of these trends were statistically significant. So what can we say about this? What does this tell us? Among this particular cohort of urban MSM during compared to pre-pandemic, we saw significant and sustained decreased sexual behavior. We saw increased HIV and PrEP care engagement, and while we saw initial declines in STI testing, this rebounded to pre-pandemic levels by the end of 2020. And we saw no statistically significant changes in either chlamydia or gonorrhea, and I apologize, I did not show the chlamydia today. We did see some important differences in risk behavior and STI positivity by race. So among Black MSM, there was no change in the likelihood of reporting multiple sex partners during compared to pre-pandemic. And among non-Black MSM, we saw significant sustained decreases in the number of total, new, and casual sex partners observed throughout the pandemic. We also saw substantially higher STI positivity among Black compared to non-Black. But no substantial differences in actual access to sexual health care by race were observed. Some of the limitations were the challenges in biologic testing. Our sample sizes were limited for statistical testing. We had a number of unreturned testing kits. Then that means our results may overestimate positivity if symptomatic participants were more likely to return their kits. It also may underestimate positivity if those at highest acquisition risk were less likely to return their kits. The information on chlamydia and gonorrhea symptoms were not ascertained, but otherwise characteristics of those tested versus those that were not tested were similar. And we can't say anything about syphilis and HIV acquisition because those were suspended throughout this observation period. There may be social desirability or attrition biases influencing our results. And our study population was drawn from a convenient sample in one city and therefore may not be generalizable. What are the implications? This does suggest that the impact of, because of the limited change in STI positivity, that the impact of mitigation measures have been limited. The impact of decreased number of sex partners may have been sufficient to offset, but not overcome the impact of increased prevalence of untreated infections due to disruption to clinical and prevention services. Despite declines in number of sex partners, the underlying sexual network structures that facilitate transmission may not have been sufficiently altered. And this may be particularly true among Black MSM, among whom we observe fewer and smaller declines in the number of sex partners and higher STI positivity. And we do need to do more work to examine how network characteristics change over time and how that impacts transmission. But encouragingly, care engagement increased. This could be a result of attrition bias towards those individuals that are more inclined to be engaged in care. But it's also possible that some of the alternative modalities that were deployed during the pandemic remove some barriers to retaining people in HIV and PrEP care for some individuals, and that's worth further exploration. We also saw the STI testing rebounded to pre-pandemic levels during the end of 2020, and this suggests that the severe disruptions in delivery of some sexual healthcare services may not have been as severe or prolonged as we initially feared. Another encouraging sign was that we found no evidence that racial STI disparities were being exacerbated. So if we combine all this information together, the severe declines in patient volumes and subsequent service delivery reported among BCHD clinics, they were similar to those observed in other settings. Our patterns of reported gonorrhea diagnoses were also similar to those observed in other settings. And our analysis of the SUN and the UShine data suggests that the overall disruption to sexual health care services may not have been as severe or prolonged as feared. And this is due to some indication that patients were able to receive care in other acute settings when they couldn't access care at the sexual health clinics, and that the shifts to telemedicine and the utilization of syndromic management may have been effective in delivering some services to individuals who would have been at elevated risk for gonorrhea infection. And that overall, the impact of COVID-19 mitigation measures on transmission may have been limited. There are some concerns that remain regarding the potential for increased transmission among MSM, and specifically Black MSM, given those high rates of positivity that we were still monitoring. And we will continue to examine trends in positivity. There are concerns, given the changes in who was being diagnosed, that there may be disparities in access to care among youth, women, and those without insurance, especially since these are the populations that are disproportionately served by public sexual health clinics. And our findings underscore a need for frequent STI testing and treatment in impacted populations, and a continued call for a novel strategy to deliver these services to people where they are. And finally, no one person can do this. We are a village, and this definitely took a village of people to conduct. And so my intense thank you to all of those, and first and foremost, participants who donated their time and answered our questions for both UShine and SUN surveys. So any questions? Yeah. So we collected gnat samples, which are outside of a research setting, are typically not then tested for resistance. Resistant strains in Baltimore, from the surveillance systems that are in place, we tend not to see the early emergence of resistance for gonorrhea. Certainly, if we did, there would be an alert and whatnot. But so while we were unable to look at that specifically, I don't think that would have been an ongoing issue, at least more so than normal. And in fact, less frequent treatment would help actually mitigate the resistance problem.
It blocked my mind hearing that the ER doesn't always test for HIV when people have positive results for other things. Is there a theory behind that? I can imagine there would be some sort of burden with reporting, but.
So some EDs in Baltimore do, and there's been a lot of work to routinize HIV testing and EDs in Baltimore City and in fact across the country. What it comes down to is reimbursement structures and training of staff. So one of the things is, EDs and urgent care, they're very focused on the complaint at hand. And so there's both getting the clinical staff trained and in the habit of doing this, but then there's also the patient, training them to ask the patient in such a way so it's not off-putting, right? So you're there because you have a drip and you really want this thing taken care of. You may not be as receptive to HIV testing. So there's a lot of work to be done in that area, and it is being done. We focus mostly on EDs, and there's been, like I said, a lot of programs among emergency departments to increase and just, hey, you're coming in, we're just going to test everybody for HIV. You can opt out, and Maryland does have opt-out testing. It's a little bit trickier in the urgent care setting, but that is an area that we've actively been trying to explore.
really jealous that our research isn't as exciting as the research in Baltimore. But my question was just around when, the next pandemic comes, what, if you could ideally sort of change the system, what would be sort of some of the solutions to make sure that we have consistent care? Is it like making sure people still stay in the clinics and the clinics stay open? Or is it using the EDs as sort of the secondary provider when needed?
So one thing that I think we all learned was that public health workforce development is an important aspect that we are lacking in the United States, or there's a severe need for additional workforce development, particularly for things like contact tracing and emergent public health response. Now, Congress had designated a boatload of money to this endeavor. It was given to the CDC. They were in the process of funding lots of workforce development trainings across the country. And as part of the budget deal last spring, much, if not all of that, was completely rescinded. I think the other thing that came out of this, and I think where improvements need to be made along those lines, is if you think about the infrastructure of a state or local health department, who is doing the most contact tracing? And in part because of the sheer volume of disease and just it's the STI and the HIV prevention programs within the health department structure, like that was where the expertise lied. And so that's kind of why there was so much redirection of resources, because those were the groups that knew how to do it. So I think just sort of a broader approach to public health and emergency preparedness would help us with that. I think also we were lucky to be living in a virtual world and environment with technology. So even, 2 decades ago when we started our public health career, like the telemedicine aspect would not have been an option because the technology just wasn't there. And I think in a lot of arenas, while it wasn't perfect, it did allow for care delivery. And I think there's things to be learned of how we can make that better. Because certainly if your routine follow-up requires some laboratory tests and a conversation with the doctor, that doesn't necessarily require you to go to the office. You can go to a local site to get your blood drawn, or where there's also work that's being done to explore ways to mail at-home specimen collection kits, and even at home, can you have a Zoom call and do your test and read it with a navigator or a clinician right there, then and there, and then they'll call in a prescription. So I think there's ways that we can utilize that technology for people who want to use that. Some people are going to want in-person visits. And so I think that's a good model. I think also we, in the midst of all this, we got through Omicron, and then Mpox hits. And that's, Mpox, there was a vaccine available already, a longish incubation period, not as much asymptomatic transmission as you find with COVID and other respiratory diseases. So there were a lot of things about the pathology and natural history of Mpox that worked in our favor, but that we mobilized very quickly. And, that's like a classic epidemic curve, peak down. We do still have some endemic, transmission going on here and there, and we're going to have to pay attention to it. But I think we did learn a lot of lessons in that, so it's a lot depends on the pathogen.
I may have missed it at some point.
Mm-hmm.
Those are the things we're tested for, controlled for. But how did SES or other socio-demographics sort of come into play in terms of, I guess, access and testing, and may influence solutions? Because I know at Baltimore, the white and black is a big thing in Baltimore, but even more so than that, from literally block to block, you have very high disparities in terms of access and ability to care and testing sites and those kinds of things. Even culturally can be different in neighborhoods.
So in the U-Shine study, which was a cohort study, we were recruiting in large part persons who had sought care at an STD clinic, were positive for syphilis. That's what the point at which they were recruited. We recruited from PrEP clinics. So that was a cohort that is, at elevated risk of acquisition for syphilis in particular. That was the group we were looking for. And so while there is some variation in socioeconomic indicators, it's much more of a uniform group, and the race is effectively or can be a marker for some of those indicators. It also was a highly insured population. I think it was 80% of that population reported health insurance. So in terms of, we don't have a lot of variability in that particular cohort to look at those differences. The SUN data, which is a representative sample of everybody who has received a gonorrhea diagnosis, we did see indicators of differences in terms of who reported having insurance during compared to pre-pandemic. So there was a higher proportion of individuals with reported gonorrhea diagnoses during the pandemic that reported being insured compared to pre-pandemic. And that's a little bit worrisome and suggests that perhaps there is a socioeconomic divide in terms of who was able to be diagnosed with gonorrhea. But from that data alone, I can't say whether that's a transmission and, there's just a difference in who's getting gonorrhea, or if that's an access to care difference. But certainly that is one of the indicators that is sort of worrisome, that there is a disparity that may have been playing into what we can and cannot observe in our surveillance data.
Was something like zip code or location area collected for participants, or would that have been could you see it?
So I could look at, and I haven't looked at if there's been changes in terms of census tract. And census tract of residents, if there's very blatant changes during compared to pre-pandemic, and perhaps that's something, thank you for the suggestion to look into. What we do tend to see in Baltimore is this persistence by geography in the state, the same areas light up, and there's two networks of concentrated HIV, syphilis, gonorrhea, chlamydia, structural racism, segregation. They're all the same census tracts in the city, and we see this effect go on and on and on. And that suggests somewhat that that's where there's high prevalence networks. And so even if behaviors are the same in one, from one group of individuals to another, the acquisition is just going to be that much higher because the pool of individuals you're hanging out with and therefore having sex with is higher. But yeah, looking to see if there's indicators in census tract, and particularly census tracts where there's high degree of poverty and lower educational attainment, could bolster the claim that hey, there's the people who are probably most likely to be infected or were not getting tested. Yeah.
I know this is outside the scope of your analysis, but do you have a sense of how Baltimore cities?
I don't have a sense of overall transmission patterns. I do know that our clinics were unable to, or the return to services has been a little bit slower at the Baltimore City clinics and in some other places. But that's certainly not a universal trend. We have looked at clinic volumes in the SUN network, and Baltimore was a little bit slower, but everybody remains suppressed through the end of 2021, I think. And then Omicron, so the beginning of 2022 shut things down. We haven't yet been able to look much at 2022 and 2023 data. There was a cybersecurity incident in the state of Maryland And so that there's been a lot of work to deal with the recovery from that. And so we're just now being able to sort of look at those data again. But certainly STIs have continued to rise. One of the problems that I haven't touched upon here that's certainly happening across the country is the enormous increase in congenital syphilis cases. And one of the hypotheses about that is decreased access to care among women who use and abuse substances, and we're not seeking, inability or unwillingness to seek prenatal care. That's an extension of a trend we were seeing prior to the pandemic, but certainly the pandemic has not helped. But we are seeing, increases across the board, across the country, and in particular, some really, really bad outcomes. You had another question?
I actually moved from the Midwest to the East Coast during the pandemic, and I would just note anecdotally that services seem to be much more shut down on the East Coast than where I moved from. So I'm sure that has some effect.
Like New York completely shut one of their clinics and it didn't reopen until I want to say 2022. And it was just, the resources weren't there, and continually diversion of clinical staff. And then I think as we were all coming, okay, we got a hint on this, people, the hospitals aren't filling up anymore, et cetera, et cetera. The East Coast also was slower to rescind some of their other restrictions. MPOX hit, and the same group of, DIS and clinicians and clinical space and visits were devoted to the MPOX response, which was appropriate, but it also ate up some resources.
Partially answered this with your comment about congenital syphilis. But I was curious, this is a fabulous analysis, and it really tells us a lot about what some of these changes will happen to our sort of surveillance network and everything. But is there long-term health implications, sort of like long-term complications of these diseases that we are observing now, that not necessarily the different trends that maybe we're treating them later or catching them later or whatever, but are we noticing impact to the public health that probably is due to this interruption of the
So I don't know of any actual observed trends. A few things that could happen that we should be on the lookout for is, many people believe that you can clear gonorrhea and chlamydia naturally without treatment, but that doesn't always happen, particularly for women. Untreated infection is a known cause of pelvic inflammatory disease, which is quite painful, requires hospitalization, it's expensive to treat. It's also a leading cause of infertility. So down the road, we could see an uptick in those two conditions. Gonorrhea, and in sexual minorities, gonorrhea infection, chlamydia infection, syphilis infection, particularly rectal. For gonorrhea and chlamydia, it's particularly the rectal sites of infection, are associated with increased HIV acquisition and transmission. So it could impact the overall, and threaten to reverse some of the enormous gains we've made in terms of HIV transmission, in addition to the impact of less testing, less access to care for HIV and pre-exposure prophylaxis. In terms of syphilis infection, you can long-term, if the longer you live with syphilis, the higher the likelihood, although it's not, contingent on how long you've been infected with syphilis, but you could start to see more neurologic involvement, optic, otic issues. Certainly you can have those problems with recent syphilis infection as well. And then the congenital, for those of you who are not well versed in the sequela of STIs, at any point in your syphilis infection, regardless of how long, a pregnant woman can pass the bacteria to the fetus, and it can have very devastating consequences, including severe birth defects and stillbirth. So there's a lot of, downstream health impacts that we maybe have not been able to observe yet.
Take one last chance and say.
I hope there were no Zoom questions.
No.
Okay.
Yeah.
Yeah. Put that over there.
Oh, you're welcome. Thank you.